Welcome everyone to today's meeting of the Health and Social Care Select Committee at the London Borough of Hillingdon. This meeting is being broadcast on the Council's YouTube channel, Hillingdon London. The purpose of the committee is to monitor services provided by health partners in adult social care and review their performance. We also undertake in-depth reviews and witness sessions on specific topics and submit our findings to the decision-making cabinet. My name is Councillor Nick Denys. I'm chair of this committee. Before we start, I have some important housekeeping for everyone present. Please ensure that any mobile phones are on silent. We're not expecting a fire drill, so if the fire alarm does go off, please follow Nikki out of the building. Please keep your microphones muted when you aren't speaking, then unmute to speak. As chair, I will call on those to speak during the meeting. It's worth noting that some of the participants on this committee may be using devices to access agendas and papers for the meeting. So we're now going to move on to the agenda. Nikki, do we have any apologies for absence?
Chair, there are no apologies for absence.
Do we have any declarations of interest? No? Great, fantastic. Item 3, the minutes from the meeting of the 17th of February 2026. Does anybody have any comments, or are we happy to pass them? Yep, okay, so unanimously. And item 4, exclusion of press and public. Every single item is in public, is that correct? Yep, fantastic. Okay, so we can move on to our main agenda items. So today we're doing one of our biannual or half-yearly health updates, where we have the main health providers in Hillingdon come and tell us about what they've been doing over the last 6 months, and we get to questions. So we're first off going to start off with Vanessa Odlin from the Central and North West London NHS Foundation Trust. So can you give us a brief summary of the important stuff you want to highlight that's been done over the last 6 months, and then we can move into questions. Thank you.
Lovely, thank you, Councillor Denys. So I'm just going to pull out a few things from our update. I firstly want to pull out the expansion money that we've been given for our urgent care response team. So they focus on supporting patients rather than going to A&E, to keep them at home with a response time of 2 hours. And they also will support keeping people at home for longer, up to 17 days. So we've got the expansion money, we have recruited into that team, and staff will be starting over the next 4 weeks. The Lighthouse, which we've been here before to talk about, which is our space that's very close to A&E in the Hillingdon Hospital to support patients who come into A&E who are experiencing a mental health crisis. So that you'll see from the graph has had an increase, which we're really pleased to see in terms of people coming through from A&E into the Lighthouse. We are taking much more of a kind of a pull-across model, so really getting the Lighthouse staff to come into A&E and support people coming out from the moment they've come through. Obviously making sure that people who need support around their physical health get that in the first instance. And we're working with primary care. Our next phase in terms of the Lighthouse is looking to see whether we can have that as an open access walk-in. But obviously we want to be cautious around that because it is within the Hillingdon Hospital estate. I also wanted to pull out, I know we were here last month, or my colleagues were here last month to talk about our CAMS update. But wanted to pull out the work that we've been doing around neurodevelopmental assessments for our children and young people in Hillingdon. So we were lucky to get some additional one-off money from the ICB, which has seen, so obviously when we started that work, the children and young people waiting was nearly at 2,000, and children and young people were waiting up to 2 years. I'm really pleased to say, so end of March next week, we will be down to 400 children, young people waiting, with an average waiting time of under 1 year. We think it's on average between 6 to 9 months, so that will be really good. We know that that's not sustainable because that was one-off money. So in parallel to that, in Central and North West London, we have established a new pathway for neurodevelopmental assessments. So we're not necessarily centralising it, we're just making sure that any learning we have from the other boroughs, we're going to have one central triage point, and any learning where things are more efficient in other boroughs, we're using that approach in Hillingdon. That will be commencing as a soft launch on the 1st of June. We think that will see a likely increase of about 50%. We'll be able to see 50% more children. We know that still means that we'll have a gap, and we are working with the ICB in terms of how we will address that. Moving on to MHSTs, I've been here before talking about the rollouts. We're up to wave 14 now, and we've had additional money coming into Hillingdon. So that will now see a coverage of actually 64%. It says 60% in the paper, but a 64% coverage across schools and having mental health support there. The plan is with NHSE and the ICB to have 100% coverage by 2029. If we can get it sooner with money coming through, we will do, because we know that that's a real priority. And very finally, on MSK, the MSK team have been doing some work around ensuring that we reach as many people as possible. They've been doing some community events around MSK, so bringing people in to see if people still need support. Can they have it there and then? In this kind of space, which they have got private space, but they're also seeing if people still actually need the treatment. So making sure that who we've got on the waiting list are the right people. That has seen the DNA rates reduce down to 7%, and they were at about 10% a year ago. And that's it from me.
Thank you so much. My sort of main question, I think others in the room might also have some opinions on this, is about the integrated neighbourhood teams, which you highlight as moving along successfully, which is great because it's a really important initiative in making access to healthcare quicker and better for many people. I mean, in your paper, you'd sort of mention that a new innovative software is being trialled in Hillingdon, which enables district nurses to write directly into GP clinic systems without duplication. Can you talk to us about what we hope will be saved in terms of time and ease of access to records, and also is there any further work going on in order to be able to share information more easily? Because for many years now, sharing information between different parts of the people who provide health services has always been one of those things that we've always wanted to improve.
Thank you. I'm actually going to defer to my colleague Amanda, who probably knows this much better than me.
Thank you, Vanessa. Councillor Denys. So the reference in Vanessa's paper is to a product called Blinks PACO, stands for Patient and Care Optimizer. It's actually a solution that sits around the existing clinical systems. So although community services and primary care, so GP practices and the ComFed, have different patient record systems, what it's actually enabling us to do is to allow a single point of entry, and we're trialling it at the moment with district nurses from Vanessa's teams. It means that on a mobile or an iPad device, when they're out and about, they can actually, if they're taking blood pressures anyway, rather than just putting it into the CNWL clinical system, they can input it through this Blink system, and it goes into the GP record as well. It means we've got a more holistic view of patients, so we're collecting information about patients from multiple data sources. This is just the beginning. That's actually quite a simple thing that we've done, but there's plenty more that we can do, so it's something that we're all working on together, and I think the opportunities could be really substantial. Been in a number of workshops, frailty workshops with colleagues from CNWL, voluntary sector and others, where the nursing teams have talked about really substantial savings to their time from not having to double enter into GP systems and into community systems, and actually releasing that time to spend with patients so we can actually take on a bigger caseload. So I know Keith and others will have talked in the past about the fact that we've got to sort of more than double the number of frail patients we're seeing to manage them really well outside of hospitals. So it's the kind of thing that's really going to enable that work.
So when will we know how successful it's been and what we can learn from it? And also another question that I have is, what are the other areas where you think this sort of approach could be rolled out with benefits? Because it's one of these things that's been talked about for a long time, and the fact it's simple is great, but simple doesn't necessarily happen quickly always. Yeah. So, but I think it's a really great idea. So we want to find out here, I'm sure, if it's successful as we hope it can be, and if it is, what other areas can we do that in order to sort of save time and increase capacity for those who provide healthcare?
So the programme of work, it's a system that we purchased in primary care, primarily initially to help enable the way GP practices work, and particularly how they work with our at-scale provision to make it easier for booking and to enable. It also has a lot of functionality that's quite helpful for patient communications, automatic translation and messaging that's much better than the core systems. So we've seen, for example, really vastly improved response rates to various health campaigns as a result of using it. So the opportunity here is to extend that to other providers. So we're kind of at the beginning of that, and I would expect that to happen over the next 6 months, really. You know, we're looking, it will require us to invest to extend at place, and actually potentially getting some funding from the ICB to do that would be really helpful. To be honest, in terms of the conditions it could help us with, it's substantial. I mean, we're focusing on frailty initially because that's where we already have quite a lot of joined up services, and then obviously in the frailty space, the community team, the hospice, voluntary sector, the Confederation, we all already work together on in the CCTs and care home service, for example. So that seems like a sensible place to start. But as I say, the pilot we're doing is actually around taking hypertension readings, which is another big priority for us as a place. It could be extended to any number of things, because it's actually it's almost like a layer or glue that sits around the various clinical systems and enables them to talk to each other, so we can effectively see a single patient record in cases where we want to.
So, Sue and Sean from the ICB, I mean, this sounds really good, but if the pilot does work, I mean, do you think there's potential to fund this type of working? Because I think ultimately the future savings in terms of time and capacity sound really good, but is this something the ICB might be looking at?
It absolutely is. So just to be clear, when we're now talking about the ICB, we're now talking as from the 1st of April of the new joined ICB, so across 13 boroughs, across West and North London ICB. And digital as an enabler is absolutely one of the key current focuses of discussion. That falls a bit into two buckets. There is a whole piece of work across both ICBs around data and analytics and population health data platforms, and how we roll out and maximise the use of the whole systems integrated care. So that's about that we understand who the populations are, and I think at an ICB level that is at the moment taking a bit of priority, because that will help with the whole commissioning element of it. But there's a whole additional, which is the operational digital, and the ICB is currently in a series of workshops with colleagues at place, beginning to talk about a whole range of different things, and the last workshop was talking about digital, and Amanda was talking about the Blinks platform that she's just discussed here. And at an ICB level, we are thinking about, because there's loads of different platforms out there, and wondering, so the pilot will be really helpful in helping inform investment decisions. But definitely the ICB is keen to learn and think about what future investment decisions there may be.
Something that we'll come back to, I think, in the future. Anyway, does anybody else have any questions based on Vanessa's presentation? Yep, Tony, Councillor Bells, even.
Thank you, Chair. Just interested in your figures on the lighthouse and the increase in numbers. What is the average length of stay at the lighthouse? Do you know?
Sean's got it in his report.
Sorry, it's a good tag team today, isn't it? Moving across. So, I'll just find the right page, sorry. Yeah, so as we say, if I just go through a little bit of the Lighthouse then, because I know we've discussed it quite a few times actually. So initially the revised Lighthouse model sort of came into effect in around November. And when we started off, we moved that up to see the capacity of around 4 to 6 patients per day as an increase. What we have seen since that's happening, we've seen average patients going through there from around 11 to 25 per day, and it's seeing an average, it used to see around 1 to 2 patients per day, it's now seeing up to 4. So it's quite a big increase. Actually, some of that has been driven is actually in the average length of stay, and it's actually reduced from by about 52% from when it started. So it used to be, average length of stay was around 27 hours. So you can have more people, that's why you'd only have the 1 to 2 patients per day, because you've got a few patients that are in there for a few days. We're actually now around 13 hours as the average. I mean, that was in January, and I believe it has improved slightly in February as well. So the target is to try and keep the average length of stay of patients below 1 day. And actually, the throughput, in a way, is around 67% of those service users are now returning home, or returning home with support. With most of the referrals coming through from actually A&E and the UTC, so that patients aren't actually even getting to A&E, they're being picked up really quickly and moved over and supported in the Lighthouse. And I think what Vanessa was talking about recently, a couple of weeks ago, mid-February, they're actually expanded the service further to support up to 10 patients per day, and that's the sort of next step piece of where we're looking to support patients from primary care as opposed to actually having to have gone through to A&E so they can move straight into the Lighthouse. But that is a piece of work that would take a little bit of time to make sure the pathway is correct for those patients. But so far we've seen some really good improvements, reduced length of stays, greater support for patients home, and actually for ones that don't get home, support into sort of mental health wards and stuff.
Just to add to that, I think the last time we reviewed the data, it was 15% of patients were converted into going to a hospital, a mental health hospital admission. So the rest were either supported home, or there's the in-between bit where people are using the crisis house, the retreat, the crisis house, so people are being supported to go there.
Thank you. Very good news. Yeah, I'm impressed. Thank you.
Thank you. Councillor Martin.
Thank you, Chair. I was just reading about the community service expansion, and I appreciate it was only in late 2025, a few months ago, you got the extra funding. Could you give us some more information on what the urgent community response actually does? Because it just mentions that it supports patients in physical health crisis. What sort of demographic of health crisis is that? And do you have any target reductions in numbers of people being admitted to hospital or A&E? Because that's always a bonus. Thank you.
So in terms of the interventions that the urgent care team and hospital at home function will do, so they'll do anything they possibly can, to be honest. So they are also supporting any sort of physical health service, anything really. So what do? They look at supporting people with who might be on the heart failure. They might be starting off to be on the palliative care pathway. So yeah, they'll see as many people as they can. In terms of the what was your second question? Sorry.
If you are looking at percentages, or you have any targets in mind?
So we haven't actually got any targets in mind. The target that we're actually, the reason that we were given the money is to make sure that we move as close to 100% as possible. So any patient that's referred in to the urgent care pathway, that they're seen within 2 hours. So at the moment we're probably averaging around kind of between 70 and 80% of patients seen within 2 hours. And obviously if some patients aren't seen within 2 hours, it may be that they then end up going into A&E. So that is the metric that we are capturing in terms of the team. But of course we are also looking at number of patients that are going into A&E as a whole Hillingdon place. We want to make sure that's reduced as much as possible.
Great. So, Keith, you just want to come in on that?
So just to put that into context, instead of the target for urgent community response, we have a target linked to the hospital redevelopment programme, and that's to reduce non-elective admissions and ED attendances. And I won't steal Leslie's thunder, I'm sure she'll report this as well. On both those metrics, we are doing well against the new hospital redevelopment target. So we are seeing less non-elective admissions this year than we did last year, and there are fewer ED attendances this year rather than last year. So I think that's an important thing just to bear in mind, but I'm sure Sean will cover that a little bit later.
Amanda, do you want to come in on this as well?
Yeah, I was just going to add, we're also piloting a senior clinical decision maker, which is essentially a GP working alongside Vanessa's team in that team, 7 till 7, 7 days a week, 8 till 8 actually, sorry. And that's also enabling quicker decision making, decisions that can be made that the community team couldn't make on their own to be made, prescribing, and also supporting the mobile diagnostics, which I think you've heard about previous meetings as well. So again, another thing that's joined up.
That sounds really good, actually. I like all these pilots because they're all about working together and trying to make things more efficient and quicker. So again, that's the kind of thing that we'd be interested in hearing about how that goes later on once we know. And that'd be really interesting. Thank you. So I think that segues very nicely to our next person who's going to be presenting to us, which is Leslie Watts, Chief Executive of the Hillingdon Hospital NHS Foundation Trust. So Leslie.
Thank you. So I'll start actually where our colleagues have finished. So I think A&E performance actually, so we have seen slightly less patients coming into the hospital. The performance actually is pretty good. So the national performance at the moment is around 74%. Hillingdon is at 77.6%, I think, at the moment. This is year to date, so better than the national average and actually better than the London average. Good news is that, as you will know, Hillingdon was in the Oversight Framework 4. It's now in Oversight Framework 2, and in part that is because of the response to, I think it's got about the best ambulance handover in London. It's increased its performance around ED.
Could you just explain what Oversight Framework is and why it's good to move from 4 to 2?
Well, there's some similarities with scrutiny, actually. So it's the NHS sort of type of scrutiny that goes into quite a lot of detail into everything that we do. So the quality of care that we deliver, the operational performance, which I'm just talking about, how we look after our people, and indeed our money. So
is that the NHS basically moving you up to a better division with less sort of scrutiny because you're doing better? I'm just sort of translating in
you're doing a really good job.
Thank you. Good. So essentially, it's good news. The NHS are happy with the improvement in performance.
So absolute real improvements, and it is on objective data. So this isn't just opinion. This is data. This is what the data tells us. So. Emergency department performance much better. We will hit our referral to treatment performance, so that's the people that are on our waiting list. We had to get to 60% of those seen and treated within 18 weeks. We're above that at the moment. If you've looked at the 10-year plan, which I'm sure you have, it says we've still got to do a lot better, but again, pretty good. I can't remember if I said this the last time I was here, but we will hit our financial plan, and that will be the first time in 10 years that Hillingdon has hit its financial plan, which is, and indeed we're thinking that, given how near we are to year end now, that we'll have a very small surplus, which is, again is a good thing, because actually it has meant that there is money being given to acute units who do meet their financial plan. So that is very good news as well. I mean, in nearly all areas, in all areas we've hit our plan. That doesn't mean there isn't more work to do. We've still got quite a lot of patients so 60% still isn't where we would want to be in terms of patients waiting on the waiting list. Our performance around the cancer performance in terms of the 2-week wait is very good, but actually in terms of treatment 62 days, again, alongside many other hospitals, we've still got some more work to do, but we're working hard on all of those things. We talked a little bit about the ICB being brought together with North Central London. You will know that on the 1st of April, Hillingdon, along with Chelsea, London North West Hospitals and Imperial Hospitals will be coming to a group with one chief exec, and we've been doing a lot of work with all of our partners, with all of our staff to prepare for all of that. Tim Orchard will be our chief exec, and we're looking forward to working really well with him. We already have a pretty close relationship, actually, so that is good news. The relationship actually between Chel West and Hillingdon has been a really positive one as well, and some exchange of staff, some learning from each other, which I think has helped both organisations, both in terms of the successes we've had at Hillingdon, but also Chel West learning from some of the work we've done at Hillingdon has been a really positive thing as well. You will have seen that our chairman has stepped down, and we have an interim chairman who's Bob Alexander, very experienced, previously Chief Financial Officer actually of the NHS, and he is acting chair. But we retain Carolyn Downs as our vice chair. And of course we're working really hard to ensure that we continue to make progress with getting the new hospital built, and that's again been very positive and a lot of support from everybody in this room actually, so a big thank you for all of that. We, I think, have managed, we hope, to have secured the money for the high-intensity users, which again is something that we are working together with, both in terms of making sure those patients get much better care and consistent care, but also actually their attendance at ED can be quite disruptive, so working very hard on that. And there was a question about whether that would be funded this year. We think we've managed to fund it. And just to go back to the previous discussion, I was asked the other day, given all the work in terms of Hillingdon Health Partners and how successful it's been, whether we shouldn't continue with expanding that pilot site work from this new expanded ICB, and I think what we've said is yes, we would. So thank you, but happy to take any questions.
Thank you for that. My first question is about the Hillingdon Hospital rebuilt. We here have been talking about almost 4 or 5 years, saying it's happening, progress is happening, which is all great. And from my perspective on the Hillingdon Hospital side, brilliant work, getting it ready. Jason spoke to us many times, along with others. So where are we at with it now? I mean, obviously we know we're towards the front, we're right at the front of the list, which is great. But what's happening with the list? I mean, is there sign of progress? So,
yes. So we continue. You will see. I think Jason does bring updates here actually, but we could do another brief. But we're continuing with some of the decamp work. So that's moving some of the patients, some of the services out of the buildings that are being used at the moment, so we can take those buildings down to clear the site, ready for that build. You will know that there's been some discussion about the size of the build. The basement of the build. I think we've got to a position where there was an issue about the cost of doing the basement, frankly. So where we've got to is, okay, if we don't put what we were going to put in the basement, how else might we accommodate that? I think we've got to a place, more or less a place of agreement. We will be talking to you because it slightly changes, I think, the height of the building, which will be a discussion with planning. But I think we're nearly there, actually. There's been, I think, a new appointment to oversee the new hospital programmes with NHS England. Again, a very seasoned hospital chief exec, well, not ex, I shouldn't say that. Actually, he'll think I've done him out of a job. But I think a very sensible appointment that will understand how we do need to move this on, because people become cynical. What we've tried to do at the hospital is said, don't become cynical. We have to believe we're going to do this. It's really important that that expectation continues, because we do want it to be built.
Thank you. Obviously, every argument about money delays the build, which makes it more expensive, which is quite ironic.
We've secured the money.
But we are. I mean, I'm not cynical. I'm very optimistic. I know that a lot of good work is done. We're just frustrated about the actual sort of pace of it. But anyway, good stuff. Does anybody else have any questions? Yeah, Councillor Martin.
Hello. Just a very quick question on the winter. It's great to hear the improvements on the statistics and everything that you've achieved, because it cannot be easy operating in the density of Hillingdon. How has the winter been? Have you seen a decrease in COVID admissions? Is that finally tailing off? How are you with corridor care and the flu that goes around in the winter? How have you managed to keep out of the sort of what's the terminology hospitals use when you see it on the news sometimes when they sort of declare an emergency because they're under stress? How have you managed to avoid that?
Well, I have to say I'm not a lover of corridor care, and I think there is something that says when you start to expand into places like corridors, it's very hard to pull back from that. I would say it was with the help of many people around this room. So we have looked at our length of stay. We think very hard. Vanessa's leaving, but we talk to each other on a frequent basis about why our patients are in hospital and whether they can be cared for outside. I'm pretty strict about, I think I might have said this before, which is if anybody's smoking outside that hospital door, there will be a real question for me about why they need to be in hospital. If they can move themselves from a ward outside, there's a real question about why they need to be there. So I think really getting the whole hospital to understand that sometimes we describe hospitals as very safe places. They're not the safest place in the world, and we know that patients decondition, they get infections, all of those things, and changing the mindset of staff in terms of risk, and the real risk actually of looking after patients in corridors is not something that we would want to see. And staff have really engaged in it. I think we should be very proud of the staff in that hospital. They really have engaged in the discussion about how we better think about the care that we provide, how we balance that risk, because often there's that thing that says, oh, I'll just give them another day or two because it's a bit risky to send them home. And I think balancing that risk sometimes is a discussion that needs to take place every day. And I think we've tried to embed that. We've done a lot of work around deep dives into every single specialty in every single ward. And that has really, again, engaged the staff into what their responsibilities are and how those responsibilities can be shared and escalated if they need it. So all of that, but I absolutely, Vanessa's gone. So I would say it can be quite challenging. I absolutely think that other parts of the system really have stepped up, be that the Ambulance Trust, be that our colleagues in mental health and community, and be it our GPs in the whole neighbourhood, the drive for neighbourhood. I still think there's a lot to do. I would have said, I thought it was a really good question about urgent response, because we have got to get more than responding within 2 hours. We've got to deliver some practical things, and everybody in this, from health in here will know I say IV antibiotics at home or in nursing homes, something around falls, something around end of life. If we can crack those things, our hospital will be fine.
Yeah. What's your preparation for the resident doctors' strike?
Oh, God.
It's not far away now, so,
no.
I mean, or what is the impact, I suppose, and how are you trying to mitigate the impact in the best way possible, is a better question from me.
Yeah, so for those who don't know, we got the news yesterday, I think, that our resident doctors, the BMA resident doctors have voted to go on strike straight after Easter. And that's disappointing, frankly, but, and I think I've said this in here before, they have the right to withdraw their labour. What we're trying to do is to, and actually many of them are very good about this, to establish how many of them will be coming into work. They don't have to say, but many of them do. And we're hoping that there will be increasing numbers who do decide to come into work. Having said all of that, as you know, last time it was particularly at Hillingdon, it's a small hospital. I would say it was challenging. So we will not plan to cancel anything, because we don't really want to cancel any of our cases, but we will have a priority list of the order in which we will cancel things if we have to. It does mean that our consultants will have to change what they're doing, and it does mean that we will think about things like leave and study leave, all of those things, and think about just bringing people in, but it is a disappointment.
Does anybody else have any questions? Yes, Councillor Punja.
A question and also a congratulations note on hitting the financial plans and having a surplus at the end of it. I think that's no mean feat in today's circumstances. And I just wanted to kind of circle back to the, you talked about hitting all the plans that you had already in place, and that cancer treatment was one of the places where you wanted to be improvement. I just wanted to understand what treatments and kind of where are the gaps that you feel need improving.
Yeah, so I think that the early 2 week way of seeing everybody and putting them on a pathway is getting some of the definitives. We call it 62-day. Patients treated in 62 days. In many specialties we do hit it. In some specialties we've got some work to do. I'm happy to give you the details of which, if that's helpful, because we have it by every single specialty. Yeah.
Okay. Thank you, Leslie, for that. That was really good. Look forward to hearing about how it all goes in the next 6 months. So
thank you.
Feel free to leave.
Thank you. We've got somebody who's retiring after a very long time. So
yeah. Okay. Well, no. Thank you so much for coming. So next we have Samrin Nashin. Sorry, Noshin. I need to get glasses. Is it written down here? Yep, I need to read my notes that have kindly provided to me by Nikki as well. And you're from Your Voice Hillingdon,
from
Healthwatch Hillingdon,
yeah.
And I'll get there in the end. I was just going to ask you to introduce yourself, actually, which I should have done before trying to half introduce you first of all. So, as you're new to this committee and as your organisation has just started in terms of the Healthwatch type of work, can you just introduce yourself and your organisation, and then obviously you've provided the paper some highlights from your paper. Thank you.
Sure. Hi everybody, I'm Samrin Noshin, but you can call me Samrin, and Healthwatch Hillingdon has been there for like a long time in Hillingdon, but it's just there has been a change of provider since last year, August 2025. Healthwatches operate differently in different boroughs in the type how we are set up. So we are a local organization which are independent by ourselves, but we're funded by the council. So it's just Your Voice is the parent organization and the provider for Healthwatch Hillingdon. Under this particular organization, we have a few work streams where we basically act as an engagement company, and we go out and about in the communities to learn about their needs and priorities that we can highlight to the strategists and decision makers in the borough. We call ourselves the local watchdog, so essentially trying to understand residents' experiences and gather their feedback regarding their usage of any health and social care services in the borough. So based on our work that we've done since August, I would like to highlight a few things that we've found. We have done a patient experience program, which essentially means that we've spoken to residents in the borough from August to December, where we've spoken to around 324 people to learn about their experiences with GP practices and hospitals and other health and social care services that they've used. So this has been shared with external partners in the Health and Wellbeing Board, so it might be new to a few people here. So I wouldn't go into very broad details, but touch base on the main issues that we have found. So through the patient experience program, we've looked into GP practices and hospital experiences of people, where we've seen there has been persistent telephone waits. People struggle with that even now. People have found difficulties using online consultation systems, which is filling out the forms, mostly for people who are older residents, people who are not digitally confident, people who have language barriers. We have seen there is not much clarity around appointment pathways, meaning that people have told us that there isn't so much of transparency in terms of whether they'd be getting a clinical callback, or they would get an urgent day appointment the same day, or would they be getting a routine appointment. Then we've also found that there's low awareness of the wider clinical team which we think as a recommendation, what we have discussed with GP practice managers as well, that it might be best to sort of promote the wider clinical team for the residents to sort of build trust so that they know who they're getting seen by, if not the particular GP, because oftentimes people just expect to be seen by GP, whereas there's a whole lot of other healthcare professionals that can help them, and they're not really clear on that. In terms of hospital, we have had a balanced scene where we've seen strong feedback on staff attitude, communication, and quality of treatment. We've had high praise for these areas. There are pressure areas, and particularly in A&E, following long waits and limited real-time updates, for which we've seen that it's not so much of the wait, it's rather the uncertainty that people feel that whether they'd be seen by anybody or they would get any follow-up information by the doctors or anybody in the A&E particularly. And we've also seen that there's a need for realistic timelines for follow-up appointments. If somebody has seen somebody, the communication between the GP practice and the hospitals, how does that go forward? People lack confidence and trust in that. Based on that, we have sort of recommended, we have provided recommendations in a few settings, because we know that primary care has already so much going on in terms of managing calls and patients. And this is also a national issue in terms of handling telephone calls. But we've said that even though that's in place, if there are ways that they can optimize the telephone waits for people, because oftentimes they're varying from particular GPs, and our program is just a snapshot of what's going on. It's not based on any particular GP practice or a specific department of the hospital. We've said how to best optimize the system so that people don't get frustrated calling or waiting on the telephone line. We've also recommended improvements to online consultations regarding providing clearer guidance or assistance from the practice in terms of filling out the form digitally, and more transparency about what happens once a form is submitted, because oftentimes people don't really understand if the form has gone through and what's the next step that's going to be followed up on. And we've also encouraged practices to sort of strengthen awareness of the wider clinical team so that people know who they're getting seen by. In terms of the hospitals, we've said that sustain the excellent staff culture already in place, since there's so many people who have we've heard good praise from them, and people clearly value the compassion from the healthcare professionals and the quality of treatment and care that they've received from the hospitals. We've also said that to strengthen the triage processes and provide real-time communications, especially during waiting times, particularly in A&E, and also improve clarity around appointment availability and timelines. We've got another program called Enter and View, which is essentially where it's not an assessment, it's more like a visit to care homes and supported living accommodation, where we go and visit firsthand to understand residents' living experiences on a day-to-day basis. How are the staff catering towards residents' needs, and is there any particular thing that we can highlight as good practice that could be made standard across care services in the borough, or if there's any barrier that we find based on our observations and speaking to residents or the friends and families and even the staff in terms of management's perspective, that we can go further and recommend something. So this for this year, 2025 and 2026 cycle, we've focused on nursing homes and supported housing, where we have been able to have some constructive conversations with the staff and look around accessibility and signage of the house, environment and cleanliness of the house, activities, engagement and communication, and also staff well-being. This has led to recommendations that, and also actually this is a program that has been very well received by both the care providers and the residents. We have had some very open conversations with the staff and at the same time residents, where these areas have been touched, and to be honest, the care homes that we have visited have been so far very good, and we haven't had huge major concerns that we needed to flag, but apart from the few facts that people, the residents and the families, with friends and families, they would like to be more involved in regards to being informed about their loved ones, the care, how they care about them, and at the same time, how activities go on in their care homes where people sometimes feel isolated. They would like more family involvement. So, and I think, yeah, that's basically the highlights from the entry and view visits that we have had. One of the reports have been published from our websites. It's on the Parkfield Nursing Home, which happened to be a very good care home. Based on their last CQC inspection, where they requires improvement, their rating was requires improvement, and after our visit, we can see they've clearly improved from their past inspection. So that's something that we have highlighted to the provider, and going forward, we are also planning to build a care home strategy to highlight good practices that we've been able to observe in these care homes, which can be shared further with all the care providers to enable them to sort of facilitate conversations within their staff and management systems. Last but not the least, we are doing a hospital discharge project, trying to learn about people's experiences post-discharge and the transition back to the regular lives once they leave the hospitals, and how the communication from the hospital has been with them in regards to their whole discharge process. And we've just started this project, I think, day before yesterday. Our patient experience program's first report is available. I think we've just published it today, so it's publicly available to everybody, and it's been published through our website. And the other reports are kind of being drafted and will be published soon by the end of this month. Yeah. Happy to take any questions.
Thank you. I think and welcome to the committee, obviously, and welcome to Hillingdon. I know you've been here a little while now, but the first time at the committee. I think it's so important having, your organisation or any organisation doing this work and finding out what patients think across the board in different areas. My question is, how do you decide what to prioritise in your projects and what to investigate in? Because we struggle knowing what to investigate and to what level, because there's so much you can investigate. But how do you as an organisation decide what you're going to sort of focus on and what information you're going to get?
Brilliant question. Thank you for asking that. We decide by speaking to you. We decide by talking to the hospital external partners, and mainly by speaking to the residents. So every year what we kind of do is we have a plan of going out to the communities and talk to them that what would you like us to prioritize on? What do you want us to find out about what services that you're struggling with? Is there any... So every year we kind of do is a priority chart based on the priorities in the borough that any services that we've heard from is, say for example, national priorities. So we do a chart of those things, those priorities, and go out to people and ask, these are the things that we have come across. Do you think this is an area that you would like us to focus on? If not, what would you suggest that we do? So that's the resident part, how we engage with them and give them the floor to sort of come to us and say, this is the area that we want you to look into. And besides that, we also talk to our external partners, whether it's the hospitals, whether it's primary care, whether it's CNWL and NWL, with other voluntary sector organizations. We gather everybody's views and we sort of act upon those priorities. But please bear in mind, we're a very small organization, very, very small team, but that's how we kind of talk to our commissioners based on what we gather and decide on what can we do in the coming year.
Is that on a rolling basis, or is there a specific time when it's useful for us to tell you what we think is important, or is it a case of we just tell you when, we come across something that we think is important?
It's a bit of both. That's because we usually come up with a work plan at the end of the year when we're summarizing the last year and we're trying to plan ahead what's going on. But at the same time, oftentimes that we see is it's kind of rolling basis in the sense that besides the actual KPIs that we have to deliver, if there's scope and space for us to look into other priorities based on our resources and staff, we are more than able to incorporate that, and we roll that out.
When your organisation is considering, what to put in the work programme, it'd be useful to let us know what your deadlines are, because I'm sure we'd love to give you some information, but we'd love to give you that information when it's most, useful for you. So if you could find out and let us know, and I'll let Nikki know, that would be super useful.
Absolutely. You should be expecting an email from me very soon.
Thank you. Good. Does any other councillors? Yes, Councillor Bassett.
Thank you for that update. I just wondered, when you mentioned GP access and also the hospital experience, whether you know of any examples from your data and the feedback that you've gathered of best practice in the area. For example, my GP practice has improved a lot in the last few years in terms of the sort of access for patients, the phone access, and they've got a new online system and various other ways that you can contact them. So I think that could be an example of best practice. And I was on a transport panel for the new orthopaedic elective centre in Northwick Park Hospital, and some of the things that they did in terms of their communication, they really listened to people, and also the fact that they've been able to bring together so many different boroughs and take the operations to one centre seamlessly. I think that would be another example of best practice, for example.
I think I've touched more on the challenges of the GP access, but I'd again reiterate that this is a snapshot of our program. But it's when it comes to best practices, as I had said about challenges about online consultation, I would also like to highlight that that was a positive theme that we had drawn upon, that people really appreciate how quick and fast it can be. For people who are digitally adept, it's very adequate and very handy for them. So that's a compliment that we had received. So these are the kind of things that come across, that one particular team can act as something a barrier and also as a compliment in here. So staff culture, people having good treatment, that has been highlighted in both as a positive and also as something that's emerging to be a struggle for a lot of people. So that's where we tend to sort of highlight which are the people that they're not being able to get the right support there. But besides that, we don't really identify a particular GP practice or a particular ward or department from a hospital unless there is a request from a particular GP practice, and we are able to give that.
Thank you, very helpful.
Thank you.
Councillor Hager.
Thank you, Chair. Great report. Healthwatch have always been so crucial, I think, to actually getting, the real truth about what's happening and around with everyone else. So one of the questions I've got is, we've got down here, which is what I really love, where the challenges you're still facing at the moment. There are two areas, aren't there, here? There's the operational access barriers, the misalignment with local priorities. How can we help you sort of tackle these? Is there anything particular that you're looking at, especially with the misalignment with local priorities and the limited awareness of Healthwatch, which you have touched on already? But what can we do to actually perhaps tell more people or get it out there and actually understand what Healthwatch does?
I think it's a bit of both. We have tried to raise awareness by ourselves because we engage with people in a lot of different capacities. We go to engagement events, we attend partners engagement events. Right now today, before coming here, I've received an email from an engagement invitation from the GP Confed. So these are the kind of things that we go to raise awareness, even within some of the partners. So one of the challenges that we were facing was getting access to GP practices, because one of the ways that we collect patient experience is essentially going to GP practices. But we've been facing a bit of resistance in the sense accessing particular GP practices, because I think it's not mandated on them to let us in. So, and I think that's why we sort of highlighted that even though there's a lot of help from external partners, we have had communications through the Confederation. They have released the first set of communications for us to kind of liaise with everybody. Our commissioners have liaised us with the ICB to get into touch with every particular PCNs in here, and we have done that. But there seems to be a lack of awareness or a sort of misunderstanding in terms of because this is not mandated, and this might seem, there's a lot of survey out there, whether it's from the NHS, whether it's from the hospitals, there's a lot of surveys out there, and which is true, people might be confused that why are you doing the same thing on and on, over and over again. But I think the point gets missed here is that we are an independent organization, and we talk from people's perspective, and whatever they're saying to us, it's more like we're giving you a very unbiased view of what people think. But the reason it's in there is because I would welcome everybody's perspective and suggestions in here. If there's anything that we could do differently, because it'd be a waste of if things are already being done in the borough in a similar fashion that we're doing it, it'd be a waste for our resources and time doing the same thing if you're not being able to inform you all on what needs to be done. If things, based on how things are going forward, there's a possibility that Health Watch will get disestablished from next year onwards, which we still don't know because things haven't moved onto Parliament yet. So but as long as we're here, we want to be supporting our external partners. We want to be representing local people's view. We want to be the independence. We want to bring in the independence of people's voice here, and bearing in mind how commissioning lines goes forward. Is there anything that we can do to help support partners better? We're more than happy to have conversations, take people's views in consideration as we chart out our work plan going forward.
Yeah, thank you. And I think that's well worth us taking on board to see what we can do. Maybe, I know we've done it in Hillingdon People before, but maybe do another relaunch. Also, I think Carers Trust need to have a good network of GPs.
Yeah.
So maybe try and tap into their network of GPs and see if you can cross-sector them. I think they got I think they might have got about 70% access to the GPs, but we do know that it's a challenge.
Yeah.
But I don't know whether Carers Trust might be able to help you with that. Thanks.
Thank you. I mean, we benefit greatly from having an independent organisation researching what patients in the local area think in order to help us do our work. So, and whatever happens in the future, we would want to maintain that, definitely, because, to scrutinise, you need to know what people think well. So thank you. Okay, so if we're happy to move on to the next speaker. So I'm going to go to Dr. Richard Grocott-Mason. You're a bit nearer, so my nameplate readings are slightly better, from Royal Brompton and Harefield Hospitals. So if you'd like to give us a quick update based on the paper you've submitted, and we'll ask some questions.
Yeah,
thank you.
Certainly. Thanks, Nick, and thank you for the invitation to come and speak. So just for context, I'm a cardiologist and chief executive of Harefield and Royal Brompton Hospitals, but that includes also the group that I'm chief exec of includes the heart-lung critical care services of St Thomas's and Guy's hospitals as well. So I cover a wide geography, and again, the patients that we treat are defined by their disease rather than by their geography. So we treat patients that come from a very wide area. So a few highlights of performance. The health system, we're no different for that, under a lot of pressure, as you all aware. We've had a big focus on trying to make sure that we've got no more patients who've waited more than 65 weeks for treatment, and we've eliminated people waiting over 65 weeks. We are on target for trying to make sure that we've got patients treated that aren't waiting more than a year for either to be seen in a clinic or for their definitive treatment. We've still got concerns around the cardiac surgical waiting times and the pressure on that number, and that really hasn't recovered post-COVID. And that's a London-wide problem. Leslie mentioned the cancer 62-day performance, and again, we we treat patients with lung cancer, the surgical part of the pathway with lung cancer, and the target to get people from the initial referral through to having a surgical operation to remove part of your lung for lung cancer in 62 days is a pretty challenging one on all sorts of different levels, particularly as we have patients that come in as a trust from multiple different hospitals in a wide area, and often there are delays in getting the diagnostics and things at all different levels. So our performance on that metric is not as good as we would like it to be, or where we're asked to make it. But the outcomes for patients are very good when they do get to treatment, and also there is a big revolution going on in the way of lung cancer in terms of screening programs and earlier diagnosis. And it's one of those cancers where actually the shift to earlier diagnosis is the biggest impact on survival. So it's a good news story, but actually through the lens of the 62-day target, it's one of the problem childs that is a complex pathway. Diagnostics, there are pressures on echo and sleep are the two things which are particularly challenged in getting diagnostic tests done within 6 weeks. Sleep is an interesting one because the number of referrals for assessment for sleep disorder, obstructive sleep apnea, has virtually doubled because it's one of the criteria that enables people to get access to the weight loss drugs. And so it's, I think, an unintended consequence, but it then drives a demand for diagnostic tests. Transplantation, I just want to highlight that. Some of you may have heard the BBC File on 4 story that was broadcast the last couple of days or so around the challenges in heart and lung transplantation in the UK. Harefield, we had I'll say record year, but certainly the highest number of transplants. We had 71 transplants year to date this year compared to 62 the previous year, and we of that 41 lung transplants, which again is our largest number of lung transplants for at least 5 years, with excellent outcomes. So that is positive. On the financial, we also will meet the financial plan as a trust overall, although it's been pretty difficult and tricky. Some good news in the way that NHS capital funding comes through. We've got secured funding for a new Da Vinci robot for thoracic surgery to help with the lung cancer treatment that will be installed in Harefield for the next month, and also funding for a modular extension build that we're aiming to put in for April 2027, with some funding in the next financial year, but the bulk in the following year, to again increase the capacity predominantly to deliver a service that's in the paper called navigational bronchoscopy, which is again where using robots the team can reach smaller and smaller nodules that are picked up to make an earlier diagnosis and to increase our capacity for treatment. Continue to have excellent patient feedback and also a positive staff survey that was recently reported with still challenges, but staff in the survey who recommend the hospital as a place to work and a place to receive treatment well above the national NHS averages. And then the resident doctor strike, very difficult and challenging for the type of patients that we have. We try not to, or try to cancel as few patients as possible, but because of the emergency workload and the hospital is full of very sick patients, bringing patients in for elective treatment at a time where we might be under pressure is quite difficult, and coming at a period of high holiday time as well is going to be quite difficult for us. Happy to take questions.
Thank you very much for your paper and your summary of what's been happening in Harefield Hospital over the last 6 months or so. The robotic stuff sounds absolutely fascinating. My sort of broad question actually is about demand for you as a hospital, because obviously you are known, rightly so, as being a leading hospital in this area, so you can get patients from across the country. Does that affect your ability to manage your sort of waiting lists when potential demand is so big?
A short answer is yes. It's quite tricky, I think. And again, if other hospitals are under pressure, then patients can find the the demand to go somewhere else, and as well as the patients on the elective waiting list, every day patients appear into hospitals all around the place where they need some emergency treatment or urgent treatment before they can go home. So the pressure on trying to manage about a third of our workload for cardiac surgery is patients who've presented through A&E or through a heart attack centre for urgent treatment. So getting that balance between those things, and of course when patients are in hospital waiting for treatment, the teams in those hospitals will try to find multiple different hospitals that can deliver that treatment. So it is difficult, and I think balancing there are changes in the way that the funding flows are happening with the devolution of specialised commissioning, patient choice, and then also the flow of money to following the patient is not as clear cut as it used to be, which makes that quite difficult. And then when you are held to account for the operational performance, again, those things are hard things to square.
I think it's useful to know the context, so thank you for that. I don't provide any solutions for that problem, but it's useful to know those pressures that you're under. Councillor Martin.
Thank you, Chair. Congratulations on the 41 transplants. You must have done 2 in the last week, because it mentions 39 here, so well done on increasing those numbers. You mentioned there's considerable pressure on the cardiac surgical waiting times, but earlier this year in Harefield Hospital in particular, about 1 to 1.5 of the wards were closed for 1 or 2 months of the year. What sort of impact does that have on your targets and waiting lists? And was those closures funding or budget related, or was it staffing levels related?
No, thank you for that. And yes, they're a little bit like buses, where it's not a predictable level for transplantation coming through. A number of reasons for bed closures. Part of the bed closures during these last 6 months were for some ward refurbishment work. The funding and the staffing go together, obviously, because we can have the bed space, but the staff to treat them are generally. That has not had an impact on the amount of treatments that we can give, because we're trying to reduce length of stay and all of these other efficiencies. And if anything, the limiting step for us is much more frequently either the theatre capacity or critical care capacity. And one of the difficulties, again, of running the services is we have obviously the transplant service, and some of those patients can spend quite a lot of time on critical care both before and after transplant. We also have the heart attack centre, where we get patients again from a wide geography who come in and may take quite a while to go through critical care. So at different times the operational pressures are on that. It is so even if we opened more beds, we wouldn't necessarily be able to get more people through the theatres. But there is a huge amount of pressure to keep the beds so that we only have patients in hospital who need to be in hospital for the reasons that Leslie and we're all trying to do this. That being in hospital is not the safe place to be if you don't need to be in hospital. So there's a lot of work going on in that.
Thank you. And just a quick question. You mentioned, I think the Chair mentioned that the hospital is widely regarded for the level of care it gives, and the retention of staff at Harefield is remarkable. I mean, some of the nurses have been there 50 years or more. You did a survey which was favourable about how people feel the morale of the staff at Harefield. Was that done prior to the merger with Guy's and St Thomas's, and do they feel the same being part of a larger organisation, do you feel, than just being part of the smaller Harefield organisation?
Yeah, the survey is the national NHS staff survey, which is the same questions to the same across all of the organisations, and it's done every year. So the results that we've just received, I think, were surveyed in September or something. Nods of people who know more about the timing. So you get the results only a few months before you're actually surveying people again. I think the results are not that different, to be honest, compared to when Brompton Harefield was a standalone foundation trust compared to now. If anything, the changes are more related to pandemic, COVID, pressures of society and everything else, but the same issues appear and the same positive things are there with the results. I think most staff who work at Harefield feel they work for Harefield Hospital first and foremost, before GSTT and before the NHS. I think there's a lot of local pride and loyalty to the hospital and the history of the hospital and the services that they do. So I think at Harefield the merger has had positive effects because we've had some investment in the electronic patient record and various things that you get from scale. Some of the people feel more positive and others feel more negative, but that's kind of life in general. But from the majority of patients and staff, I'm going to say, I don't know if this is being recorded, but they probably don't even know that apart from the paycheck recorded and it's going to be published. Okay, well, it's probably the name on the paycheck has changed, but not a lot else.
Councillor Chandel.
Thank you, Chair. It's like Councillor might have stolen half my question. So, which was staff retention. So what's your, it's a very specialised field that you're in, so what's your staff recruitment like then? Do you struggle to get new staff in?
Generally, no. And we are well staffed, but there are particular staff groups where there's a national shortage, and some of the pressures of London and the cost of living in London has particular issues, and the groups that we are particularly impacted by: physiotherapy, occupational therapy, radiographers, perfusionists. So some of the more specialist scientific staff, and I think there is I don't think the NHS always does brilliantly around the additional workforce that isn't doctor or nursing, because the kind of delivery of health and lung care is a multi-professional sport, and we need the whole team. And I think everybody knows that doctors and nurses work in hospitals. I think there's a whole range of scientific professions and that are not always well publicised. So I think that there could well be, and we've looked and thought about, but there's so much else going on, we haven't got round to finding a solution, but how you really get young people into taking up these really interesting roles, and particularly with all the technology developments and things, you know, there's fascinating jobs to be done, as well as the caring element that I think people just don't know about. So those are the areas where we struggle a bit, and they're often quite small teams. So when you have absence for either sickness, maternity leave, annual leave, or just the turnover, that can be quite difficult on the rest of the people trying to deliver the service.
Thank you for that. I think you guys do a grand job then, and unless you're in that, you've had to experience that, you don't realise that there is a bigger team around the surgeons and the nurses that need the help though. So I don't know what the solution to that is, how we can actually help you, or you can help yourselves to actually find a recruitment process. But no, thank you very much.
Sue, you want to come in on this?
Thank you for your question, Councillor. I just wanted to add to what you were saying. Across Hillingdon Health and Care Partners, it's now about 18 months, maybe even 2 years ago, we did a hard to recruit to survey. So we surveyed all of the partners across all of the professions asking kind of what were the kind of key staff groups that were hard to recruit to. And OTs came out at top, with every organisation struggling to recruit OTs. Now, we've no solutions to it. There's something I think we need to do, we could sensibly do collectively. Our local authority colleagues, THH, CNWL, all really struggling for OTs, and it leads to our long waiting lists for our therapists, for our children, young people, on the neurodiverse pathway. It's problems in frailty in our care homes and care home assessments, all of that. It's a real professional difficulty challenge for us. I think there's something potentially about how we work with Brunel, who they are a local academic university for therapy training and qualification. So for me, that is the one profession. If we do anything together collectively, that's the one profession we could and should be doing something about.
Great stuff. Well, thank you for that, Richard. We'll move on to the next people. Thank you. So finally, and I'm going to take you as a group. We have Keith Spencer, Managing Director of Hillingdon Health and Care Partners, Sue Jeffers and Sean Bidwell from Joint Borough Directors from the ICB, and Amanda Carey McDermott, CEO of the Confederation Hillingdon CIC. So Keith, if you can start, and then Sean, or as you wish, you decide how you want to do it yourself. This is your moment, and then questions. Yeah. So we're going to go one voice with Sean, and then questions will open up the whole can of joint work.
One voice with me and Sue, actually. Before the meeting, we did promise Keith that he wouldn't need to talk today, and to be fair, I have all these paperwork in front of me, and everyone has already said pretty much everything I was going to say. So I'm actually going to just consolidate a few things that we've said already. So I think about a month ago we came, myself and Keith, and actually we gave the update of HHCP, achievements and progress that we've made. And to be fair, the updates we've had from all the partners is still that update, because they are all part of the partnership. And so I might just shout out about a few of the things. So obviously we can see we are seeing improvements in our A&E numbers. They are going down. Improvements in performance, they're going the right way up. We're also seeing reductions in some of our long waits. So actually some of our 12-hour attendances of waiting in ED have reduced about 35% actually this winter compared to last winter, which again is a real positive. We've gone on and we've talked previously around, we've improved our discharges. So, some of the process that we've done on no criteria to reside, just to remind people, that is the patients that medically don't need to be in hospital, and we've been working towards getting to a 34 target, which is 34 patients per day, no more. When we started the work, we was around 50, and we have hit that target, but we have been around last 10 weeks around 36. So again, we're seeing some improvements there. Wider than that, we've talked about the hospital redevelopment. Actually, when you link back to the hospital redevelopment, when you look at our papers, sometimes people will say there's a lot of acute measures in there. And actually, they're the acute measures that we need to get to meet the needs of the new hospital. The delivery of that is the work that we do locally to support that. So, we've reduced down our non-elective admissions, actually. We're seeing less non-elective admissions now than what we need to be seeing in order for the new hospital, so we're achieving that. We're not quite achieving the average length of stay that patients are in hospital. It's called the bed days, basically. We've reduced the non-elective stay, but we haven't quite hit the average length of stay, and that is what we need to move to in order to support the hospital build. In addition, there's some other things. We're always coming up with numbers, unfortunately, because we were here 4 weeks ago. There was a few other things I thought I might just put out there. We've recently been doing some work on some of our what we call care home residents, and looking at A&E attendances from those residents there, and non-elective admissions. And actually, what we can see this year compared to last year, we've seen around a 25% reduction in the number of A&E attendances from care home residents, and actually a 33% reduction in the non-elective admissions. So less are actually being admitted. If I bring that back to some of the conversations we had earlier when we had Vanessa and we was talking about urgent community response, actually part of that wider urgent community response is some of the work we've been doing under reactive care, and we now have sort of the reactive care coordination hub that kind of went live in December. It's going live in phases. First phase of that was bringing in the urgent community response team. It has brought in things like, you'll hear the phrase, senior clinical decision maker. They're your GP leads that are there supporting the team. They're also working alongside with the community diagnostics, and some of that is going out into care homes and identify. So your urgent community response team will go out, see a patient, bring the diagnostics in. Actually, you're able to see their needs there and not have to take them into hospital. Same with frail patients, people in their own homes. That's the sort of services that we're supporting and delivering on there. Leslie mentioned kind of three things. She sort of said, the three things that we can do to support is, the IV antibiotics, falls, and end of life, actually. And I'm not saying we've hit it, but things like we now have an IV antibiotic service that can support patients at home. That's jointly run. We've got a service run by the Confederation and CNWL to working together to provide that service. We talked about falls. We've got some of the falls training that has happened and gone out to the care homes to support them. And we also have a full service run by the voluntary service that brings in some physio work there for people that have had falls or at risk of falls to get them stronger. And there's some services from the local authority around strength and balancing, so there's those sort of elements. And we also talked about sort of end of life, and actually I'll probably just bring into some of the work that's been done on the Universal Care Plan, you might hear it referred to as UCP. There's been lots of work being done on the Universal Care Plan for patients in care homes, have a really good high volume of patients that have a Universal Care Plan, so that is a plan in place to support them. What do they want to see happen to them and work to them? And the next stage is actually to work through and increase the number of patients in the community that have got an urgent care plan, so there is alternatives for them to support. So I'm not going to go on for too much longer. So I've talked about some of the improvements. I suppose what I did want to say is our next phase is not about sort of new schemes and services. It is securing and maintaining some of that grip and control that we've put and accelerating the delivery. So how do we bring the next phase of that through and to ensure it continues? So we've hit the reduction in the criteria. How do we maintain that and continue that forward? We've reduced non-elective admissions. How do we actually start to impact on reducing the length of stay and stuff like that? And I know, Sue, did you want to give an update on the children's updates you had? And then maybe I'll pause there, ask some questions, and then do we want to do the ITB bit at the end?
Sue, I think, Sue, if you wanted to give your update and then we'll go into questions on everything you said and also in the paper. Yeah. So, Sue, go.
So there's two elements. I'm wondering, so just one on children and young people mental health, and then if we maybe pause then for questions, and then I'll just give a quick update on the ICB and next stages on the ICB and the kind of plan around that in engagement with the local authority. I know that when Keith and Sean came to the Health Select Committee about a month ago now in February, the deep dive was on children and young people and essentially children and young people mental health and young people on the neurodiverse pathways. At the same time as that was happening, one of our GP clinical leads has been working with his colleagues with practices across Hillingdon, and he's been rolling out what's called a CYP mental health universal referral form. So 95% of our practices have taken it up and are using it. It was rolled out in October across all practices in Hillingdon, and it basically he's worked on creating the referral form with psychiatric colleagues, child psychiatrists in CNWL, and pulling together, so there's only a single referral form for the GP to use, and it means that the pathways into CAMS are then much clearer. But because the pathways are much clearer, because the information on the referral form is much clearer, it means the GP can engage with the family and the young person who's experiencing mental health difficulties much more easily. And as a result, his first stats are in, and there was a 17%, so it was rolled out in October, 95% uptake, a 17% reduction on CAMHS referrals in December, and a further 18% reduction on CAMHS referrals in January. So it's really helping make the GPs make, I suppose, better, clearer decisions in conjunction with the young person and their family before they actually use the universal form and refer in.
I mean, that's fantastic news, because that's something that sort of we highlighted, not just us, but we highlighted as being one of them, problems, that people referring to CAMHS too often because they weren't able or felt able to go to other solutions. So that sounds very positive. Yeah. Good, fantastic. Do we have any questions on this part? I'm conscious that we discussed both of those items very much in detail a month ago, which was great. So, yeah, go on, Councillor Burst.
Just one point, Chair. I heard on the news today that there's 70,000 children in the country on antidepressants. Do we know any figures for Hillingdon at all?
I don't, but I certainly can. We can certainly ask and find out, and pass the information in through Nicky.
So the thing I'm most interested in actually is the ICB stuff, because the North West London ICB felt a bit remote at times, and now the merger with the Central London ICB to create this new super ICB, which is, I think, probably the biggest in the country by far. So yeah, I'm interested to know, really, I mean, is Hillingdon still going to get the support and the autonomy that we deserve, essentially, with this new super ICB sort of overseeing us or being over us? So any sort of information about how the merger is going to work, and specifically how we're going to be okay with the merger, would be very useful.
Yes, it's not complicated, it's a challenge. It's a very big challenge, merging two organisations. But the new ICB will be up and running and on the 1st of April. So the new board is in, and the new non-executive members have been appointed, and so it is going to be there in a week's time. We have been through a consultation and the completion for both ICBs, staff in both ICBs, and the completion of that consultation has, the proposal was that there would no longer be a ICB borough presence in each local authority area, and that is what will go forward. That is what has gone forward as a result of the as a result of the consultation. That said, there is still a very clear mandate on the ICB to engage with its now 13 local authorities, and that mandate comes from, so on the 17th of March, so just last week, the National Neighbourhood Health Framework was published, and it talks about neighbourhood teams. So you will know that in Hillingdon we have 3 neighbourhood teams: South West, South East and North, and it talks about neighbourhood teams delivering coordinated care with social care colleagues and communities to meet population health needs. There is a really clear expectation on the ICB, and it has its own ambition and expectation about that. So there's a clear expectation about understanding the population, which is now 4.5 million across North West and North London, where their health needs are, and to reduce the disparities in health inequalities. So that is a big focus and ambition for the ICB, but there is a clear expectation that that is done and worked in conjunction, in joint commissioning conjunction with each of the local authorities. it's all done in conjunction with and overlaid by the medium-term financial plan, which runs to 2029. And within the medium-term financial plan, so you've heard a lot of data and delivery over the last 6 months. In the medium-term financial plan, there is a set of national metrics that are expected for partners at place to deliver. And within that, there's a 10% reduction in non-elective admissions of people with mid to severe frailty by 2029. The number of people identified as at end of life, an increase by 10% by 2029. We've talked about plan care here, a diversion rate of 25% on outpatient referrals by March 27. So that is a significant challenge. And for our A&E target weight of 82%, so Leslie talked about hitting 77%, 82% by March 27. So that's the national metrics for the ICB to deliver and for all partners to deliver. Within that, there is an expectation that the ICB and its local authorities that it works with agree shared financial principles, including around the BCF, during 26-27, so this coming year, and that we agree our neighbourhood footprints in each of our borough areas. We confirm our intentions on our BCF pooled budgets, and for 27-28 we have a joint local neighbourhood health plan for each of the 13 local authorities that West and North London cover. So actually, as a result of the merger and a result of the consultation, yes, the local team, the ICB local team, who is currently here, won't have a local presence, but there is a clear national expectation on the ICB that there is proper engagement with each of its constituent local authorities, and that is done as a partnership, and that the local neighbourhood health plan is a joint deliverable by both, as with the understanding of the BCF pool budget. And all of that is overseen by the JOSC. So I think as the new board gets up and running, and the exec team have been in place since October, actually. They went through their consultation in October, so we've had a single exec team since October. I think there will be a clear expectation mandate on them as to how they engage with all of the, including Hillingdon, produce the local neighbourhood plan, and have real clarity as to how the joint, because we've got a North Central JOSC and we've got a North West London JOSC, I'm assuming now that will start to become a joint JOSC, and how that works and oversees that delivery. So in a way, I think there's a bit more national mandate and scrutiny that the ICB does work in partnership with its local authority colleagues.
My initial observation is, if decision making is delegated to a local level, more so than has been in the past, then that can work well. And obviously, if we have, obviously very sad to be losing our borough representation, because I don't see you as ICB, you're just part of the team. You know, everyone here is part of the sort of, Hillingdon team, which is brilliant, and that's exactly how we should be working. But as long as we are able to, escalate issues and get decisions as quickly as possible when we need to, but hopefully decision making is devolved enough that we won't need to do that often, especially if I would say that we have a certain level of trust that we can deliver partnership working on a local level in different neighbourhoods, which I think we show here very well. So if that is the way of working going forward, that can be successful in my opinion. If, on the other hand, it comes into, we look at the 4.5 million and we make decisions based on the 4.5 million, I worry a lot about that, because the 4.5 million dilutes actually what we need here.
So I would say two things about that. One is exactly that there is a real focus on place, and the integrated reporting essentially that you've seen here tonight, that partners work together at place, and the way that we work here, that decision making then is devolved down, and yes, you have a broad brush framework from the ICB, but essentially how you get on and do it and deliver it in partnership is exactly the direction of travel. I think it is really helpful for the role of Hillingdon Select Committee and Scrutiny to make sure that actually that does happen, and either directly but also through your representation on JOSC. I think for Hillingdon we are in a really good place and acknowledged at West and North London level that we are in a really good place in order to be able to, the level of maturity to be able to take devolved decision making. I think that is really clear at West and North London. They understand that. So I think that's there. And the other piece I would absolutely say, we are increasingly, we work together across, we have in North West London, it's much more mature in North West London, the population health management data. We are rolling that out as a tool to North Central essentially, and actually the model that we have, the whole systems integrated care dashboard, is being rolled out to London, because it is seen as a sophisticated dashboard to identify health needs, and the work is ongoing for that now. Combining that through shared needs assessments with the JSNAs for each local authority is really beginning to drill down onto where the needs are. So actually you're not trying to compare the 300,000, 50,000 people in Hillingdon as a microcosm of the 4.5 million. You are looking at where are the health needs. So actually we're at the point of identifying now that, I know it's not Hillingdon, but south of all of the local ward areas, Southall has the greatest level of need in the whole of the 13 local authorities. So you begin to then really say which are our wards that have the greatest level of needs, and that's where the funding heads to, rather than can the 340,000+ people in Hillingdon scrabble for their share of the funding for 4.5 million. That's not the way it's going to be.
Just one sort of comment. Obviously, the JOSC is the Joint Health Overview Scrutiny Committee of. I'm just explaining for other people who might not know. I mean, I do know because I sit on it. So, and it's where all the chairs of the scrutiny committees of all the 8 or 7 boroughs which are in the sort of northwest London, and we meet once a quarter and have an agenda and hold the ICB to account. Obviously, if that's extended to 13 committee chairs, we'd probably need 2 days per meeting. And though it is useful, it doesn't get into the same level of detail on as we get to here, and so it doesn't perform the same function as we do here. So obviously that's something we need to work out how to do, because to make that scrutiny body effective, that's going to be huge, having 13 people on it. Okay, no, thank you for that, but that's something to keep abreast of. Does anybody have any questions about this? No. It's all very technical but important, unfortunately. Okay, well, thank you so much. I assume this might be your last meeting with us, potentially. Well, thank you so much for all your contributions and your help and sharing information with us and being part of the discussion about how to, join up services the best way possible in Hillingdon. Very much appreciated. So, as I said previously, it doesn't feel like there's different hats worn. It all feels like part of a team, which is really good. So thank you so much for that. Okay, I think we've come to the end of this agenda item, haven't we? Fantastic. Okay, well, we're going to move on to the next agenda item, but those of you who are here for the health updates are very welcome to leave, and you can take some cake out if you want to. For those watching online, Nikki's made some fantastic muffins, which you have to trust from me are fantastic. So those in the room can appreciate them, and then we'll move on to our next agenda item in a second. go. Thank you very much. We just had a little break there while people left and for others to get drinks and stuff, because we've had that first agenda item always goes on for a long time. It's very well worth it. Okay, right, so we're on to our final substantial agenda item, which is the budget and spending report, Select Committee monitoring. We have Sandra Taylor here, who's Corporate Director of Adult Social Care and Health, Martin Storey, Head of Strategy Finance, Adult Social Care, and Matt Davis, Director of Strategic and Operational Finance. So, Sandra, Martin, and Matt, how would you like to present this?
I think we've agreed that I will kick off with a brief financial explanation, and then Sandra can speak to the interesting parts. So this report is a little bit out of sync with the reports that the other select committees have had. Because of the timing of this meeting and the cabinet meeting, we were able to report on month 10 figures. Everybody else has had month 9. So when you compare the results at month 10 with what you last saw, which was 7, it is 0.8 million to the worse. When you compare it with month 9, it's only 0.6. There are 2 things that explain most of that movement. The first is a very small number, 4 or 5 older people who had been funding their own care, and typically at much more than the council would have been able to pay, and have depleted their capital to the point where they reach the threshold where they become entitled to some support from the council with those costs. There's always a delay when that happens, because they're not known to us, they don't know how it works, they talk to the care home, they find their way to social care, they have to request a Care Act assessment, a financial assessment, and it can be sometimes quite a considerable delay if there are mental capacity issues, no powers of attorney, and so on. It is unusual to have 4 or 5 people suddenly appear in 1 month, but it happened. The other reason is that, like most councils, Hillingdon had been charging the cost of personal transport budgets for young people with special needs and disabilities to the dedicated schools grant. We thought we could do it, and then the Department for Education tells us, no, you can't do that unless it is people's education, health and care plans. So nothing we could do about that, and those are really the two principal causes for that. Otherwise, the situation has been stable, and I've no reason to believe that it's likely to become any less stable. I'm very conscious, apart from that we will not be having another finance report. I think the first report to Cabinet will be in July, won't it, Matt?
It should be in July. Sorry, it should be in July. We're not doing period 1 monitoring. There's so many things in closing the accounts and not enough transactions have gone through. So we'll do an end of May position. It will take us, we'll report it to Cabinet we'll write the report and report CMT early to mid-June, but that's likely to hit the July Cabinet.
So this committee won't get it until September, with the time Nikki just told me, because of the timelines. Yeah, because
that would be the implication, unless
because we don't have an August meeting.
We don't have a meeting
in August,
which is quite a long time.
It is.
Not to have.
So it can be shared by email with the committee, can't it? Before then, I assume. or I don't know. Or a briefing if the timings. I mean, this is obviously something for us to discuss maybe, after May, of how to deal with that.
I recognise the length of that delay, and we'll look at what we can do to give you information earlier in the year.
Okay, so that was all I really wanted to say, but of course I'm happy to answer any questions before I hand over to Sandra.
I've got one question on the numbers, so to speak. So my interpretation, and please tell me if I'm wrong, because it's my understanding, is there are two stories here. Obviously, the first story is there's been a 6.5 million overspend, which a lot of that was discovered early in the sort of financial year, but since then it's been quite stable. Like the 0.8 you've described why, and over 3 months and those sort of situations. Now, what I want to know is, are we going to be starting the next financial year with a better forecast to make sure that 6.5 or whatever, a big overspend, suddenly doesn't get racked up early? Or how confident are you that we'll be able to the forecast means we won't have a big overspend at the beginning of the next financial year, which I think puts everything out of kilter as we go forward?
I'm confident, for one thing, because of the growth that has gone into this 26-27 budget, both for demand but also for inflation and for rebasing. The rebasing for the 25-6 budget into 26-7 to avoid the sort of problems we started out this year with. One of the things we'll be doing as soon as we hit the 31st of March is doing a refresh of the commitment for adult social care placements. But we'll also do that same refresh on the 26-7 data. Because you roll over and suddenly people who started care, say in December, 3 months commitment, in the new year it's potentially a full year's commitment. And that will be the proof for us that the amount we calculated for rebasing was right, or slightly too low or slightly too high. So we'll have a clear picture of what the position is, and we can also profile that over the year, because, as I said, when people come into care early in the year, they're much more expensive in year than later in the year. So we can have an idea whether we think we're on trend or not. So I can't promise that it will turn out the way we think it will, but I can say that we'll be in a much more robust position to understand what's happening and predict.
Okay, good, thank you. Matt, you want to come in on this as well?
Sorry, just very briefly, looking at the budget that was set back in February, there's £18 million worth of growth that's been allocated in the budget to adults across the board. That's partly rebasing. There's about 185 million spend budget currently, so there's money in there for inflation. We know the particular problems in terms of cost pressures in that area, which is why Martin's got more confidence, because we have rebased. There may be one or two areas where all councils will come under extra pressure in 26-27. I'm thinking of fuel costs relating to SEN transport pressures. We're aware that they're coming. That wasn't foreseen when we set the budget in February. These are the sort of things why we have an adequate risk provision and reserves. It's beyond the control of the service. The contractors could simply hand back the contracts, and then we'd be in a position of having to re-procure at a higher cost in any case. Thank you, Chair.
And of course, big stuff like that happening, coming out of nowhere, if there was a bigger overspend than we thought in terms of the forecasting, but that was the reason. That would be completely acceptable, of course. But no, that's good to know. Councillor Martin.
Thank you, Chair. I'm no numbers person, but I was just listening to what you said, Martin, that I think it's great the services we offer, and I've said this before, that if somebody requires the service in Hillingdon, the service is provided at a point it's required and assessed. But 5 or 6 people cause a £0.8 million unexpected cost. Is that correct? And
sorry.
No.
5 or 6 people caused just over half of that cost. So in the movement between, actually let me wind back a bit, in the movement between period 9 and period 10, yes, there were 5 or 6 people, and I can't remember off the top of my head, but yeah, with the backdating, they're considerably expensive. And of course the council has one of the difficulties then, they're in a care home, they could be paying half as much again as what we would pay.
So I think
it's a difficult decision.
I think actually, Sandra, it'd be good for you to come in, because this is partly about service delivery and our sort of obligations as well as the sort of financial aspect side. So Sandra, you want to sort of explain how this can happen?
Certainly. So in charging for adult social care, as you rightly say, people come to us and we assess their eligible needs. Their needs are then financially assessed, and it's a national criteria, and people with any savings of above £23,500 pay the full cost of their care. We have a duty to assess those individuals, but no duty to provide care for them. If we do provide the care, then they're full fee paying, so they pay the full cost of their care. And we also charge a fee for arranging that care on their behalf and invoicing the care home and managing that as a situation. Most people that know that they have assets of higher than £23,500, themselves and their families don't tend to come to us. They tend to go into a care home and arrange their own care. Quite often that can be much sooner than somebody that we assess would be placed into care. So we would always look to home care. We would try to keep people in their own homes longer, try to support people, give them rehabilitation, and a care home is probably the last port of call for most of our residents. So if somebody chooses to put themselves into care and be paying for that care, it depletes their resources very quickly. And currently and nationally, this is a problem, and something that we often talk about as a group of directors is how do we get to grips with the fact that people need to assess how much and how long that is going to last them when they are admitted, and their families understand that actually, because the dilemma happens is on the 31st of March, they drop below 23,500, and they therefore have a right to some eligible social care. However, they're in a placement that we wouldn't purchase quite often. And so we do an assessment, and that at times can end up with us requesting to move people. And that's not a desirable approach, because people might have been there for a very long time. It meets their needs, they're very happy. However, we have a finite number of resources that, and this is not in all cases, so not everybody is in a top-end placement. Some of the people that we're talking about are in the same care homes as the rest of our residents, which are all good quality care homes. So at that point we might have 4 or 5, and it's unusual that you get a cluster, but what happens is they will meet eligible needs. They will contact us and say, can I have an assessment please? We will send somebody out to do the assessment. We'll start a financial assessment, and that could take about 2 months. And then we pick up the cost of their care. So they still could be paying some, or we could be paying for all of it. Depends on their circumstances. And so that forecast goes into this year's budget of 5 people for the rest of the financial year at around, if it's nursing care, around £1,300 to £1,500 a week each. So you get that lump, and it's backdated to the point they become eligible. So sometimes that's quite significant, and sometimes it's quite a recent thing. So it is one of those tricky situations to manage, and if we do assessments for people that are fully self-funding, we do advise them and their families to consider where they're choosing placements, how long their resources are going to last, and there is advice and information. We've got a booklet that we give residents so that they understand that. It's just a very difficult situation, unfortunately.
Thank you for clarifying that. That kind of what was the question is, because it's a particular vulnerability for an authority if you have 5 or 6 people that have chosen the top care home to pick up the bill for. How easy is it to assess someone and move them to one that we might pay for? And is there anything we can do to protect the borough? Because to put ourselves into a deficit unintended because someone's chosen to self-fund and suddenly gone below, it just seems very vulnerable.
It is a vulnerable situation. It's a national issue, and about 5 years ago there was the fairer funding arrangements. There was part of a new process around capital limits and how this would work, but it has never progressed, and so we're still with this situation that leaves us in a position where people quite often will fund themselves in a care home of their choice, because quite rightly they would, and without even realising, and it comes to light to the family, or in some way they start to not be able to pay their bills, so it comes to light as opposed to it's a strategic any kind of decision. So last year we developed a booklet for paying for social care to ensure that people understood. So when people have an assessment, when they leave, mostly it's when they leave hospital, but when they have an assessment, we ensure that they are offered a financial assessment, and when that assessment takes place they're given the details. If they're a self-funder, we can make those arrangements for them, and at that point they can disclose or choose not to. So again, it is a bit of a weakness in the whole system on the council's part, but we do our best to ensure that people understand at what point they can come to us, but it leaves us in a vulnerable position in terms of moving people. We would have to, it depends on capacity, we will have to go to court, do capacity assessments, make arrangements as to the best. But ultimately, it's my duty to ensure that we use our resources as wisely as we can, and I can't spend a huge amount of money on one person and not on another person. It has to be fair and equitable, and the cost of a package of care is what we have available. We set those fees, so it's a tricky situation, is the best way I can describe it.
Thank you for that. Is it possible for you to send a PDF of that booklet? Because it would be interesting to read that for our own learning as well. And it could also be seen as a way to backhandedly access what people might perceive as better care moving forward, because it's almost a loophole, isn't it? If you've got £100,000 of savings and you know you wouldn't be eligible for local authority to fund your care, is to put somebody into a care home for a couple of months and then you know you run out of money, and it's going to take a court order and months or years to move someone to what we would normally expect a local authority to pay, and that's kind of a vulnerability we would, I assume, hope to avoid.
Everybody's capacity assessments and best interests are always taken into consideration, but the financial position is not disregarded. So if somebody is in a highly expensive placement, we would look to ask family members if they want to continue supporting that relative. We'd look to you can use what's called a third-party top-up, so families can add to the price that we would pay to ensure that that relative stays where they are. So there's a range of options. It just is quite a tricky situation for families that is not yet resolved as part of how social care operates.
Yep. The financial reality is part of reality, though. If that process could be quickened, it would be beneficial, but I understand, obviously, there are laws that you have to go through and all that sort of stuff, so it makes it for a tricky situation. Councillor Punja.
Thank you. Yeah, that was a stark reality, wasn't it? Wow. Picking up on Councillor Martin's point there, though, which I really do agree with, I just think that, I mean, what a vulnerable position to put our council in. The other part of that 400,000 that is in there was what, and I don't know if I understood you correctly, so forgive me if I didn't, that we were charging transport costs to the DSG. Maybe I misunderstood you, but...
So, personal transport budgets for individuals who have an EHCP, all local authorities fund the personal transport budget, so each family will get that to use to ensure attendance at school. So they can use it as long as they get good attendance at school, that's fine. Are funded from the DSG. However, earlier in the year, there was a government directive to say that that could no longer happen unless the personal transport budget was identified as a criteria within the EHCP. So all of the local authorities who hadn't identified that a personal transport budget was being used for that particular individual had to refund the DSG for the money. We now have to review all of those individual cases. Doesn't mean we can't do it, it just means that they need to be added into, so if they've got a personal budget, it needs to be on their EHCP, then we can claim DSG funding for it.
So that would make sense to me. How many do we have to review, and how much more, because it feels like this is another accounting adjustment, so how much more would we have to review, and how much more would then come back? You know, the cost, because if you've got to do a review of somebody, that's a cost attached to the council. For doing that EHCP review, how quickly would that take, and how would we see that kind of transfer into the budget coming up for next year?
And what's the financial risk, I suppose, is sort of slight summary of some of that, of this.
Okay, I'm not going to be able to answer that question, and we'll get you that information. The reason is that, quite simply, I provide the transport and the EHCP work and the assessments, etc., provided by the SEND team. So I'll ask them to get that information and send it across to you. Is that okay?
Before we have any other questions, Sandra, is there anything you want to bring out of the report? If not, that's okay, but if there is anything you wanted to bring out before I see if anybody else has got any other questions, you're welcome to sort of...
Certainly. So I've just added in a bit of context, which I hope is helpful, just around some of the contacts and how you've seen the system pressure. We have significantly stabilised the pressure this year. It's holding. It's not decreasing, but it's not increasing. So, but the contacts are, as you can see within the report, a significant number of people coming to us. We're working on how we can actually, because you'll see the conversion rate is not as high as the number of people coming to us. So we're working on how we can continue to support. We've got a really high level of third sector providers that we can divert people to, and how we should build on that and build on that early intervention. Because actually the numbers, so the front door, effectively those figures are showing that our triage is very good and our early intervention is very good at managing the high demand that we have of people coming to us for support and help. And we just have to build on that all of the time and build on our assisted tech offer and ensure that we're offering people the right help that they can help themselves, building on our front door and how that can help divert people to the right level of support. Technology such as Ask Sarah, if you ever get a chance just to have a little look on the website, it's really good. Self-help tool for people to get their own equipment quickly, almost next day, delivered to them, and it helps them do their own assessment, building on our self-assessment on the front door so that we can manage that demand, we can get in front of it. We've seen a really good shift from home care, direct home care, to direct payments where people are choosing their own care provider, and that's a reduction in cost to the council, and it's a more beneficial way of managing people's wanting to manage their own care for themselves, and a better outcome. So we'll be working towards more of that for the coming year, and as Martin and Matt have both said, we've worked incredibly hard on, and I say we, but our finance colleagues and our transformation finance colleagues on our growth model, our inflation model, our numbers, and just trying to manage and look at who's coming to us, what they're going to be costing us. We know some much greater detail for every primary support reason now, what our inflation levels are, and we've set that as an average across the whole piece. But I know who is costing us the money and what those placements are, what we need to commission, potentially ourselves as opposed to other providers, because it's a cheaper model we've found to delivering care at this point in time. So we've got really a level of confidence in the budget that actually growth is in this year. It wasn't in any specific measure. So we've got real confidence going forward that this is the right answer, but as Martin says, we've got time now between now and next reporting to check and balance all of that. So I think we're in a much, much better position than we've probably been in a very long time.
Yeah, no, I do appreciate the narrative that's been put into this report and the explanation, because I think that's really useful for us to understand what's happening. 5,000 contacts a month is a huge amount. It's quite amazing, isn't it, really? Yeah, no, so we do appreciate that. One sort of comment, I think the Hillingdon Technology Enabling Care Programme deserves a sort of single meeting review of this committee, to be honest, because I read the couple of paragraphs on that, and I want to find out a lot more than we can do tonight, I think, because that's an important part of transforming how we work, and obviously we want to find out about how that's done, and also from a scrutiny committee point of view, I'm sure we want to make sure that the efficiencies are not diminishing levels of service and those sort of things. So for a future meeting, I would think that was. I'm looking at the rest of the other committee members who are all nodding and happy with that. We think that's something interesting for the future. Fantastic. Okay. Yeah, go for it, and then.
Can I just say that absolutely, just to assure everybody that technology enhances and enables. We don't use technology to replace, unless that's what somebody wants in terms of their care of to be able to be independent. So that's why we call it tech-enabled care, so that we're enabling people to live as independently as they choose to be.
We're not moving to the Japanese model of getting robots into homes. Not yet. Anyways, Councillor Punja.
If I may ask that, so this was part of our saving strategy for this coming budget that was just gone now, and what would be really helpful if we are going to a session like that for me would also be to kind of see the cost benefits of this, where we have saved the money and how it has happened, how it's worked, because I think there's some really important kind of elements to this, and that do take us to what is going to be a hopefully digitally enabled service user. And I just want to I think it would be really important to kind of look at, where those savings were made, because I believe that there are, but we don't see them quite so explicitly. And I think now that it started to take place, whereas last year it wasn't quite ready yet, now we will see the benefits of this whole process. I'm right or wrong, I don't know, but I feel that might be the case. And I would also like to say thank you for putting the narrative, because I know I've gone on about it for so long. I really do appreciate it, because it really gives me a background on what we're referring to, rather than just numbers on a sheet. So thank you.
I agree with that. So you set a good bar that you need to repeat.
Okay.
Okay. Are we happy to close this item? Are we all happy? Yeah. Sorry. Yeah. Go. Sorry, Councillor Frederick. Go.
Sorry. I just have some quick questions on table 3, please.
Yeah, go for it.
So I just wanted to understand what were these things that were in write-off or in the red. So we've got quite a substantial figure there with 2 million, which is the review of the third sector information. Just understanding what that meant. The renegotiation of social care contracts at 1.7. I think you alluded to this beforehand, Sandra, but just a refresh on that. And then there was a part of the acquisition of the care home of 162,000. There's a staffing review of 270. Just some of these things that are just now being, because it's nearly 4 million, over 4 million that is in red or written off, and I just kind of want to know what's happened to those.
Sorry. So if I start with the 2 million.
Yeah.
So we have moved that forward into next year and the year after and split it.
Okay.
It is a review of Section 117 splits with the ICB.
Right.
So it's a legal matter around how much the ICB pays for accommodation and support and healthcare, and the amount that the council pays. And we are in dispute with the ICB legally. So
yeah.
I won't go into any more detail than that on it, but we are still progressing that challenge. And just to say that our other neighbours in North West London are picking up the challenge also.
Yeah.
So we currently receive 37% of the costs of an individual that is discharged after section from hospital. And so, no, we fund 67%, sorry, my brain, 67% of all those costs, ICB fund 37%, and we believe that it should be 50-50.
Yeah, okay.
And that's what we're expecting, that's what the model is based on.
I think we had this conversation last time.
That's right,
yeah.
so that is ongoing, and I will continue with that one until we get a result on that. In terms of the renegotiation of social care contracts, I did talk about this quite early in the year last year. That was probably the starting point was just over 2 and a bit million. The point that we started to renegotiate, you'll probably recall, was when the increase in national insurance and national minimum wage occurred. So it was very difficult to renegotiate contracts because it actually cost providers more. So we're still in the process of making sure we're getting best value. So we are carrying forward again and doing some of that work to try and, but I believe we've written that one out because it's a very difficult climate to try and manage that within at the moment. And in fairness, the way in which we've managed it this year is without applying inflation in some cases. So this year we'll be resolving some of those inflation matters with providers. In terms of the care home, this is one that, believe it or not, I'm absolutely delighted with, which I don't usually say about a saving that is actually still in red, but this was the purchase of our care home and the operation of it. Unfortunately, we didn't complete until August, so we're slightly behind the curve. But as you can see, that it's actually, our registration for nursing came through on Friday of last week. Very happy. But we are already making the early savings, so we're confident that that will be picked up and delivered.
Okay, well, we'll end this unless you know, sorry, don't nod at me if you, whilst I'm ending it, unless you want to say, sorry. So we'll end this item. So thank you so much, Sandra, Martin and Matt for coming to speak to us. And you're free to leave if you wish. And take cake as well. Otherwise, the Democratic Services team will have to eat it all tomorrow, and we don't want to foster that on them, do we? No. Okay, excellent. So our next agenda item is the Cabinet Forward Plan. Do we have any comments on that? No? We're happy to just go past that one. Okay, fantastic. And the last one is the work programme, which is always funny talking about the work programme this time of year. Obviously, looking to fit in that single meeting review on what we discussed, I think is very important. I think it would be a good idea if, normally in April, which we're not having an April meeting this year, the Cabinet member for adult social care comes and speaks to us. I think it would be a good idea if they came in June. I mean, you know, after May and all that. Does that sound like a good idea on the work plan? I think we're all happy with that? Yeah? Okay, good. And, yeah. I think apart from that, I have no other comments. Does anybody else have any comments on the work plan? No? I know it's hard to think past May, isn't it, really?
Speak about the final review.
Oh, yes. Nikki just wants to talk about the final review.
So, apologies for not getting the final draft, or the draft to you today. It is almost done. I just need confirmation from officers that the recommendations, based on everything that was discussed at the meetings, at the witness sessions, just need confirmation from the officers that they're happy with the recommendations. They are actually doable. But then once that's done, I will get it out to all of you before the end, in the next couple of weeks, hopefully.
Yeah, Nikki sort of spoke to me yesterday and said, "Do you want cake or do you want the report finished?" And I said, "Cake, please," because we can do the report by email, which shows you the priority. No, you can't do cake by email. Yeah, that'd be messy. Good. Okay. And if that's sort of coming close to the end, I'd just like to thank everybody, because obviously this is the last, not just municipal year, but of our 4-year cycle. I've really enjoyed chairing this, and you as all committee members have been super helpful and fun, and you know, helping us get to the bottom of what is incredibly massive subject with lots in it. So thank you so much. Also, big thank you to Nikki as well, who supports massively and does amazing work in front of you guys and also behind the scenes. So I want to put that in the minutes as well. Thank you. So, okay, well.
We may thank you for chairing so well.
Okay, well, thank you for that. Your thank you very much. Your microphone wasn't on, so please say to the microphone on.
Thank you, Nick. Councillor Denys, for your fantastic chairing and making this a really responsible and really brilliant committee.
I do appreciate that, because you know we all have the same interest, don't we? At heart.
We do.
So good, and that was important. It's done on microphone, that one. Cool, excellent. All right, well, I'm going to bring the meeting to a close. Okay, brilliant.